So this next session will focus on a number of the key national initiatives that have been undertaken, and thankfully New South Wales, or those with New South Wales connections, have been leading many of those. Our first speaker on this next session is Dr. Tony Sherbon, who many of you will know from his time as a Senior Health Service Executive within the New South Wales system. He subsequently went on to run the ACT and the South Australian public health systems, and is now the acting CEO of the Independent Hospital Pricing Authority. So I'll hand over to Tony.
Thanks, Rowan. Great to see a lot of familiar faces. I'll rattle through a quick presentation, then be happy to take questions either afterwards if there's time or during the panel later on. So I'm here representing the Independent Hospital Pricing Authority, which is an independent organisation, not necessarily the Commonwealth. I understand Mary finished with a list of issues to be sorted out with the Commonwealth, some of which I might be able to help with, but not all of them, but I'll be happy to see how far we get today with some of those. The Independent Hospital Pricing Authority is derived from the National Health Reform Agreement, and I think you might have been through this morning, but just for the sake of my revision, because I wasn't with you, we worked to the agreement that was signed in August 2011. I get a lot of people who throw issues at me from the April 2010 or the 2008 agreement, but in fact, keeping up with COAG's part of the game these days, COAG actually reached a National Health Reform Agreement in August 2011, which was signed by all First Ministers, the Prime Minister, the Premiers and the Chief Ministers. So that's the agreement we work to if you're looking for source documents on the web. But activity-based funding, which is our key role, has been a requirement of Commonwealth funding for hospitals since 2008. And I was part of the negotiating team on the South Australian side that established the 2008 agreement. And it was activity-based funding development was funded in that agreement, and states received money. And when I was in South Australia, we received $16 million, and we spent $16 million on developing ABF systems. So when states and territories come to me and say they don't have the IT systems or the policies or the framework to develop activity-based funding, I say, you do. It's been there since 2008. I know because that's what I used to do. The 2011 agreement provides for the establishment of the EPPA as the independent source of pricing in the activity-based funding system. So what were the governments trying to achieve? They were trying to achieve 5 things. I was part of the Commonwealth negotiating team at the time, and many of you were participating perhaps in the New South Wales side of things. Some of you I know have come from interstate. The Prime Minister in particular, her instructions to our negotiating team were to achieve transparency. Everyone in this room knows that the health system changes when it's transparent, when it's clear what is exactly happening in the workplace or at managerial level. And she wanted to bring that transparency principle to bear in funding terms. So she wanted to know exactly where every Commonwealth dollar goes in the health reform agreement to public hospitals. And she wanted to be able to say, and she will soon be able to do this, exactly where that Commonwealth money goes throughout Australia, which local hospital networks it goes to, and what do they do with that money, and how, what is the activity that's derived from the use of that money. I think everyone in this room knows about 40% of public hospital funding in Australia is derived from the Commonwealth. It varies in each state. Mary will correct me, but I think in New South Wales it's around 38-39%. So the Prime Minister and the Premiers and the Chief Ministers all agreed they wanted transparency, to know exactly where money goes in the system and what is delivered for that money. They wanted value for money, to know exactly a reassurance to the public that their public funds were well spent and value was derived from that money. The states and the territories, and with the agreement of the Commonwealth, I don't think this is a contested issue, wanted independence of price setting. So they wanted an independent process through which activity-based funding prices are set independent of government, and that led to the creation of the EPPA. They wanted national comparability, which is an important underlying principle. We get a lot of pressure in the EPPA for state-specific pricing regimes or territory-specific pricing regimes, but on the principle of national comparability and our Act, we've actually acted at a national level. And of course, all governments want efficiency, want a better outcome with the dollar for an output that is derived from the inputs that government supply. So we're part of a key efficiency agenda. So governments were looking for a transparent system that gave value for money and drove efficiency in the system, but yet was independently set in terms of pricing. The EPPA is part of that process. So I'll just briefly describe what we do, and then I'll turn to a little bit about where our work's up to a little bit later on. Our role is defined in the National Health Reform Agreement. It's reflected in our legislation, which is no longer under consideration by the Federal Parliament. That slide needs to be updated. It was actually passed in November last year. So our key role is to set the efficient price, and the legislation and the agreement specifically use the term the efficient price for activity-based funding in hospitals throughout Australia. So we've interpreted that as a single national price, and as I said, a lot of states and territories don't necessarily agree with that, but across the nation we have set, or we're about to set, a single national efficient price. We're also responsible for any loadings that we determine should be added to that national efficient price, or in the case of some factors, subtracted from the national efficient price. I'll come back to loadings a bit later on, and I'll be able to tell you a little bit of detail about what we're proposing. We also have to specify all the classification, costing, data and modelling standards, most of which have been inherited from a lot of work done over the last 14 years on the National Hospitals Cost Data Collection, but all of which require a lot of work in the next 2 years to refine their specificity and to improve their applicability in the workplace. We've noticed that application across the country is very varied, and to the extent that it undermines the quality of the data. So we'll be working with you, many of you at hospital level, to improve the quality of adherence to national standards, but also in return on our side, improvement of the specificity of those standards. They're pretty general in some regards. We also have to determine the criteria for defining block-funded services. So hospitals in Australia can be either activity-based funded or block-funded, and we have to define the point at which hospitals become, or services become, block-funded or activity-funded, and we're currently in discussions with the jurisdictions about that point, but we have proposed a level for small rural hospitals, based on a New South Wales suggestion, I might say, of around 3,500 national weighted activity units. So above 3,500 national weighted activity units, hospitals will be activity-based funded in rural settings. Below 3,500, they'll be block funded in rural settings is what we're proposing. And we're in discussions with the states and territories and the Commonwealth about that. In metropolitan settings, we don't see a reason why any hospital, apart from specialist hospitals like mental health hospitals or rehab hospitals, should be anything but activity-based funded. So we're really, in metropolitan settings, seeing no reason why activity-based funding shouldn't prevail. We also have a funny role in resolving cross-border disputes and assessing cost-shifting disputes. So cross-border disputes are disputes between two states or territories, and the most predominant one here is the ACT New South Wales dispute, which is not necessarily in dispute right now, but it's always a matter of some discussion. And of course, the New South Wales, Victorian and Queensland cross-border flow issues. So we're a body that will be able to save jurisdictions time, effort, money by assisting in resolving those matters. And we do actually have a reserve power in the health reform agreement and in the legislation to actually determine those cross-border disputes if so referred. We haven't got any referrals yet, thank you, Minister, but expecting one in due course. We also have a role in assessing, we don't determine, but we assess cost-shifting disputes between the Commonwealth and the states and territories, which is not yet been called upon, but I know that there are some states who've got some issues with Commonwealth cost-shifting, and I know the Commonwealth has got some similar concerns, so in due course we'll wait to receive those matters before us. We don't determine those disputes, we assess them, but we also publish our assessment, so it'll be interesting when that comes about. So we will produce a national efficient price, a single national efficient price. We won't be producing a Tasmanian price, a Northern New South Wales price, or an ACT price. We'll be producing a national efficient price for these service lines, acute inpatients, emergency department services and outpatient services in the coming weeks. So we're in the final stages of iteration with jurisdictions right now, Commonwealth, states and territories. From the 1st of July next year, we also have to produce an activity-based funding system for subacute services and mental health services. Subacute services looks entirely feasible. Mental health services, major challenge. We really have to redesign the system from the ground up. Not the delivery of the mental health system, but the activity-based funding principles that underlie mental health funding. And we'll try and move as expeditious as we can with mental health, but it's going to be a big challenge. So we're currently busy working away on all these service streams, but in the near future, you'll see, I would expect in mid-June, if not early June, you'll see an activity-based funding system from EPPA that will define a national efficient price and classification for these services. We've been told numerous times that the outpatient service data is not good enough, and we probably see some merit in that argument, but on the other hand, there are some transitionary provisions that protect jurisdictions. I'll talk about those in a second. And in a transitionary environment, we think that we should use the outpatient data that we've got and that we should set outpatient weights and we should run with outpatient activity-based funding. We would expect to see a very significant improvement in data in the coming years. I'll describe how we're going to do that in a bit later on in the presentation. We also will define adjustments to the efficient price. So we will define, in our coming policy statement, we'll define what we've identified so far as 3 adjustments. One is for Indigenous patients, and we're in debate with the jurisdictions right now as to quantum. But there is statistically a very definite difference between indigeneity, Indigenous status of patients and their costs. So for equivalent classifications, there is a significant difference between Indigenous people and non-Indigenous people. And that's recognised in our pricing system as a loading for Indigenous patients. Unfortunately for New South Wales, there's not a lot of gain in the next loading, which is remote residents. In fact, it's outer regional, remote and very remote residents, according to the Australian government, Australian geographic classification system. We've found that people who live in outer regional, remote or very remote Australia do have a definite cost differential to those who live elsewhere in Australia, and we'll be recognising remote residents with a loading in our pricing regime. So that means if you live in remote Australia and you're cared for in Sydney or Perth, it doesn't matter where you're cared for, you'll still receive the loading, or at least the hospital will receive, a local hospital network will receive a loading for your care, no matter where it's provided. It's based on your residence. We've also found across the country, interestingly, every jurisdiction that is implementing an ABF program has struggled with their specialist paediatric hospitals and what to do about them. It's interesting, across the nation, there is a definite difference in some DRGs between specialist paediatric hospitals and general hospitals that provide paediatric care. Statistically different cost differential, which we'll recognise in terms of a loading, but it'll only be for some DRGs, and we'll publish which DRGs, obviously. In some DRGs, it's actually negative. Some DRGs, specialist paediatric hospitals, provide care at a lower cost rate than in general hospitals, but there are some, particularly associated with paediatric ICU care, where that higher end of paediatric intensive care adds a very significant cost differential to some DRGs. So that cost differential, positive or negative, for specialist paediatric hospitals will be recognised in our pricing regime by certain DRGs. Overall, it's a positive loading across the hospital as a whole. We'll be publishing our specifications in our determination. They'll largely be a reference to existing specifications, so there won't be anything revelatory in that announcement. We'll also be publishing our block funding criteria. I've already given away our threshold for rural hospitals. It's not a secret, we've been discussing it publicly for months. We also have the terrible, burdensome duty. I spent all last night wrestling with a document which I've been wrestling with for 6 months, on defining what is a public hospital service. It's a uniquely Australian issue. When we talk to the NHS pricing people, and even we've made some early contacts in US Medicare, and we tell them that we have to define what a public hospital system is. What a lame use of your time. Because they work in a single funder system, they don't need to define the hospital boundary. They've got a single funder across primary and secondary and tertiary care. But in the Australian situation, we have to define what is a public hospital system service. We have to define what is a public hospital service for the purposes of this funding agreement. So we've had a bash at that. We've given it our best try with consultation with clinicians and jurisdictions, and we've provided a draft description of a public hospital service to all the jurisdictions, none of which are happy. But we now are in the process of finalising that in the coming days. And your Minister and DG have been very helpful in pointing out some key issues for EPPA to consider, particularly in regards to forensic mental health and other services that are often not paid due recognition when you get down to an exercise like this. So we will publish in the near future a description of what is a public hospital service in Australia. It won't be campus-based, so services that reach out into the community will be included, and it won't be restricted to provider. There are some services in this state and others that are provided by private organisations on behalf of public hospitals. So it'll be service-based, and it'll be related to a set of principles which we'll publish. The reason that's important is that services that are defined as public hospital services qualify for Commonwealth funding, and services that don't qualify for Commonwealth funding under this agreement. There are other agreements, but not this agreement. And we'll also publish our dispute determinations and assessments when we get them. So EPPA products, you probably might have covered this morning, or in previous fora, but just in case you haven't. The national efficient price is used to determine Commonwealth funding to local hospital networks. It doesn't dictate state pricing, so the state can price above or below the national efficient price. And Victoria, I can assure you, is already looking at a process to not equalise, but progressively transition the impact of the national efficient price across its health services. Other states are looking at a transitionary arrangement as well. So not everyone is just going to take the national efficient price and use that to fund local hospital services. All the states can pay above or below the national efficient price when they price their own local hospital services. States still determine the volume and distribution of services. We don't do that. EPPA doesn't do that. So we don't say how much work is done in southwestern Sydney LHD or the northern New South Wales LHDs. We don't describe where and what volume of services are provided. That's still determined by the states. And we define the criteria for block funding, but the states in effect still apply those. So there's some iteration in the agreement between EPPA and the states on the application of block funding criteria. And ultimately, we do determine which public hospital services are eligible for Commonwealth funding, which everyone's going to love us for in the end. It's important to point out that the first 2 years are transitionary years. So 12, 13 and 13, 14 are years in which the Commonwealth funding to jurisdictions, to states in your case, is guaranteed for a period of 2 years at the level that's described in the old 2008 agreement. So that's a fairly tortuous sentence, but in actual fact what it means is the old funding that was agreed in 2008 is guaranteed to the state for another 2 years. There's some factors around how it grows, but I won't bother you with that today. So there is some protection for the state in the introduction of activity-based funding. That protection does not necessarily extend down to local hospital network level, but it does extend to the states. From 2014-15 onwards, the Commonwealth will be required to pay a defined percentage of growth, but it'll be an open-ended system. So if there is less activity done in a jurisdiction after 14-15, and there are, I can think of 2 jurisdictions that are planning, not this one, are planning to do less work in 2014-15 and beyond than they're currently doing. They will be paid less from the Commonwealth from 2014-15 onwards. Alternatively, more likely, jurisdictions that do more work from 2014-15 onwards will be paid a proportionate increase by the Commonwealth, and particularly in terms of the growth of expenditure. So, to oversimplify matters, in the first 2 years, relatively protected state-level guarantee, if you like, and from 14-15 onwards, a more open-ended activity-based funding system. So whatever the level of the efficient price determined will be contentious. We've already given the states and territories and the Commonwealth a figure. We gave them a figure on the 28th of March, and of course, Commonwealth says it's too high. States say it's too low. But we will set a final figure. We're waiting on some iterations from the jurisdictions, and in fact some submissions due today. Mary, looking forward to it. Give me something to read tonight, keep me up all night. And we will make some final tweaks in the coming days, and we have an authority meeting on the 30th of May, and we hope to publish soon after that. We might have to have a second authority meeting if we have to. Whatever happens, there'll be a very significant increase in transparency. And you remember, this is what our First Ministers wanted. The Prime Minister, the Premiers and Chief Ministers, the reason why they wanted activity-based funding is to bring more transparency into the system so we can know where money goes and what we get for it. And I'm already seeing, and I'm sure you've probably noticed locally here yourselves, there's a very significant elevation in interest, even in jurisdictions that already have activity-based funding, Victoria and South Australia. Very significant elevation in interest as to what exactly their money is buying or used for at local level. And we're already seeing an intense interest in our methods and calculations, but it's not only occurring at jurisdictional level, it's occurring at local level as well. So you will notice, if you work in the system, a very significant increase in transparency. My wife's a journalist, so she's eagerly awaiting the publication of league tables. I told her that she might just have to wait a bit, but it will be very clear very soon in July, June, July, where local hospital networks sit with respect to the national efficient price. We've got a debate inside our authority. I'm governed by a group of 9 authority members, and they will debate soon exactly how they publish that information. But they will publish something. So there'll be a very significant increase in transparency. and debate about where cost goes in the system. It'll be a lot clearer where Commonwealth money is going, and hopefully the Commonwealth government and others will be assured as their objective of transparency is met. But it will be very clear much clearer where that money goes at local level across the country in the near future. And it'll also be a bit clearer where state money goes as well. And now New South Wales has published for many years its budgets at local levels, but not every jurisdiction has been doing that. So it'll be a lot clearer across the country exactly where state money goes within each state as well. So there'll be a very significant increase in transparency, debate, discussion around costs of hospitals in the coming weeks. I expect you'll see an elevation in June, July, quite significant elevation. And of course, we're already noticing ministers, not only your minister, but other ministers around the country, are starting to ask us a lot of questions about exactly where their system sits compared to others. New South Wales is numerically in a good position. You're a third of the country, so when I talk about our pricing regime, you'll see in the early years you're automatically nearly set the price because you're a third of the country. But other jurisdictions are in intense discussions with us at the moment around how the system sits with respect to the national efficient price. And those discussions will intensify in the coming weeks. So we've completed, as I said, a pricing framework, which is our key policy document, in which we define the key parameters of efficiency, the criteria for block funding and the scope of public hospitals. We've completed that document on the 28th of March, and we sent it to health ministers for a 45-day statutory period for comment. Under our legislation, we have to provide our reports to health ministers for 45 days. We've done that. Comments due today. Long night tonight for the team and I. But we will make some changes. We've already had a number of key points made to us that have indicated that the first document we produced needs to be changed. But we will then publish a pricing framework, as I said, hopefully early June, mid-June maybe at the latest, that describes all of those policy issues that we've taken into account in pricing. And we'll try and build on existing documents where we can, costing specifications and the like. In parallel, we've been doing a whole lot of technical work, which is a bit beyond me at times, and I won't bore you with today, but we've been doing a lot of detailed work around the statistical analysis of costs across the country. We've based ourselves on the National Hospital Cost Data Collection. It is the best data source that we have. It's not perfect, and it's come in for a lot of criticism, but it is by far the best, and it's fit for purpose, and we'll use it. It just perhaps is a salient reminder to you all, if you manage a LHN or a hospital or work in one, that the National Hospitals Cost Data Collection is a very important part of your work, and the more accurate you provide data, the more accurate the data you provide, the more likely is you'll get a reasonable outcome from us. In future years, we're not going to leave it this late. Obviously, we started on the 15th of December, so we had to produce the national efficient price as early as we could. We claim we did it by 28 March, but we will certainly sign it off by 30 June. In future years, we want to produce a draft, at least for health ministers to look at, by the 30th of November, so you've all got more time to prepare for the impact of that decision on Commonwealth funding and budgetary preparation. So how did we price? We've sent a price, as I said, we've sent a number to all the governments in Australia, none of which are happy with it. And we've sent a price, we set a price in the first year for 2012-13 based on a fairly, I wouldn't say gentle, but certainly planned introduction of national pricing. So we've set a price that's actually the mean cost per national weighted activity unit across Australia. So there's a bell curve distribution of costs of local hospital networks in Australia. We've trimmed some outliers and made some statistical adjustments, but in the end you come up with a mean, and that's where we've set the price. And some have argued on the Treasury side of our interactions with governments that that's too gentle, too soft. I think when Victoria commenced pricing in the mid-90s, they priced at the 25% quartile figure. We're going to price at the mean. So there is some debate about that, but I don't think it'll change in the coming weeks. We will still price at the mean. That means that around half, obvious, the maths is obvious, around half of the local hospital networks in Australia have to improve if they're going to operate at the national efficient price, which is in itself is a big challenge, particularly in some jurisdictions. It does mean that because we price at a national mean, that New South Wales, by force of numbers, tends to not set the mean, but certainly heavily influences the mean. And that's something that we'll have to consider later on in due course as to whether we should really price at the mean on account of that effect alone. But having said that, for 12-13, the authority members, the 9 of them, have decided to price at the mean. In itself, as I said, that's a challenge for many local hospital networks. We'll apply those adjustments that I spoke about earlier, those 3 adjustments, and I don't think we're going to consider any more. We haven't had any strong persuasive arguments yet for any other adjustments. And we'll set the quantum for those adjustments in the coming days as we get feedback from governments. Some of the governments are arguing around the quantum of those adjustments, and we'll do some work in the coming days to refine them if necessary. So we'll publish a price and a quantum for the adjustments in the coming weeks. We're also going to publish a private patient weights list for inpatients. We can't do it for outpatients. There's a quirk in the health reform agreement which is a distinct requirement that there's no private outpatient contribution by the Commonwealth. If an outpatient receives an MBS payment, there's no Commonwealth contribution to that patient. Under this agreement, there obviously is through the MBS. But so we won't be publishing a price list for private outpatients, which in this state are privately referred non-inpatients, I think is the term you use. But we will publish a list of private patient weights. For each DRG, there'll be a weight for private inpatients, and it's different. The deduction is calculated by taking the public weight and deducting off the revenue that would be received for a private patient. And it varies from DRG to DRG. Obviously, some DRGs there's a much bigger deduction because there's a cost like prostheses costs that come off. So we will publish a private patient weight listing as well, and a methodology we described in our pricing framework. We do have adjustments for ICU stay in some DRGs where ICU is not usual. In some DRGs, ICU is nearly always used, and so you don't need to adjust. It's reflected in the cost weight. But where it's not usual and there's an ICU stay, there will be an adjustment. I'm not, the technical guys can probably talk you through that a lot better than I do, but I can. But there will be an adjustment for ICU, and this tends to negate the effect of large metropolitan hospitals. We often get asked for a loading for large metropolitan hospitals, but we find if we adjust appropriately for ICU utilisation, then the need for that adjustment for large metropolitan hospitals used to be called teaching hospitals, but every hospital is a teaching hospital now, thankfully. We find those large metropolitan hospitals are, that factor is taken into account if we appropriately adjust for ICU utilisation. I'll just finish by telling you what we don't do. We don't handle the cash. The National Health Funding Pool Administrator will be overseeing the cash distribution to local hospital networks. So if the money doesn't turn up on the 1st of July, don't ring me. I was tempted to say ring Ken Barker, but I can't anymore. The National Health Funding Pool, Mary probably is more familiar with where this is up to, she might have spoken about it earlier, is being established as we speak, and Commonwealth legislation is actually under consideration by the House of Reps next week, I think. We don't evaluate performance. Di will talk to you about the role of the National Health Performance Authority soon, but essentially performance is still evaluated by governing bodies and states and territories. So we don't say whether you're efficient or not. That's still a matter for your state and your governing bodies, and there's a role, of course, for the National Health Performance Authority. We don't determine where services go, I spoke about that, and we don't determine private hospital funding, but the private health insurance funds have been involved with us in developing our methodology and our weights. We've shared them with them, they know them, and obviously they're interested in them, and so is DVA. DVA are interested in them as well, and we've had a good working relationship with those organisations. They've been very helpful in working with us, and naturally they'll take those discussions into their own discussions with their provider organisations. But we have no role in determining private hospital funding or veterans funding for that matter. Thank you for the opportunity to speak. I'll be on the panel a bit later on, so I'm more than happy to answer questions.